Ready? Okay. Well, good afternoon. My name is Ben Young. I am the medical director of a community-based HIV care program called Rocky Mountain Cares and assistant clinical professor of medicine at the University of Colorado in Denver in the United States. It is my great pleasure to be here on this webinar that is organized by the American International Health Alliance. And I'm here to talk over the next few moments regarding issues related to challenges in HIV care, particularly from the perspective of long-term survival. We're utilizing novel technology today for a webinar. I will be speaking in English because my Russian is not sufficient to do this in your native language. But I hope that this information will be understandable to you in so much as the slides are translated to you in Russian. And welcome your feedback either in Russian or in English in the chat portion of the webinar, where my colleague Victor will be able to translate and answer questions as appropriate. The material that we are covering today is material that has been central to much of the care as it's evolved in my country. The assembling of this slide deck was sponsored in part by Beef Healthcare, and the translation supported by the American International Health Alliance. To both organizations, I'm very grateful for the opportunity to share this with you this afternoon. So to initiate this discussion, let me make sure I can work the technology and give you a bit of background. In our clinic, not so long ago, most of the patients that we took care of and most of the medical decision-making that we were faced with was related to HIV and AIDS complications. What we have seen in North America and in the European Union over the last several years is much improved survival and decreased rates of AIDS complications. The consequence of that is that patients are living longer and long enough to have additional kinds of medical complications, the kinds of complications that we had previously had been either ignorant of or did not see because of the frequency of the AIDS complications. So in this larger and newer context, one of the manifestations of which is shown graphically in this next slide, and that is the increasing age of the population of patients that we care for. So this information on this slide comes from one of the more recent American analyses, but this conclusion could be extended to other countries around the world where antiretroviral therapy has been scaled up. So in this graphic, what is displayed is the age distribution of patients living with HIV in the United States. In the orange bars are graphics from the year 2001, and in the blue bars, 2005. What's evident here is that the age distribution, as shown by this curve, has shifted from 2001 to 2005, so that the average age of patients has increased over this period of time. This information, or this kind of conclusion, has been seen in multiple countries now around the world, and results both from the increasing survival of patients as well as an increasing number of patients who are newly diagnosed or have acquired HIV at older ages. And it's a consequence of this aging population and population of patients that have survived longer that is the subject of this presentation. So a different graphical representation of this hypothesis and thesis is shown on this graphic. This is data taken from the European cohort, or EuroCETA. And here, on the left part of the panel, are a distribution or display of patients living with HIV. And on the right side of the display are HIV negative individuals. Each column represents a 10-year age in the age of the patients, and in orange is represented the proportion of patients who are living without any other AIDS or age-related complications. So one can see, for example, that for the younger population, HIV negative, the majority of patients have no age-related medical comorbidities. By contrast, people living with HIV at the same age distribution have, or fewer of them have no age-related complications, and more of them have other one or two or more medical complications. As you can see, if you look at the older age group, there are very few people living with HIV who have no other medical complications. And in fact, the majority of older people living with HIV have many medical complications, far more than the age-matched HIV-negative patients. So one can, by looking at this kind of information, one can see really two pieces of, could draw two conclusions. One is that people living with HIV seem to have a complexion or a medical makeup that seems to be older than their chronological age. And secondly, when one is looking at the issues of distribution of care and access to care, people living with HIV have more complex medical backgrounds. And it's really those issues that is the subject of our discussion today. So the next slide gives me a chance to ask the audience some questions. Among the patients that you care for here in the Russian Federation, what kinds of comorbidities do you screen for? Do you screen for renal disease, cardiovascular disease, bone disease, cognitive disease, or all of these? Only a few years ago in our clinic, really, we focused primarily on kidney disease. And my question to you, if you can try to enter this into the chat portion of the webinar, can you give me some feedback as to the kinds of circumstances that you see in your clinics today? And Victor will translate this so I can interpret your answers. Hopefully, while you're typing, I'll tell you as the circumstances have emerged in the United States and in Western Europe, we have seen an increasing number or have an increasing awareness of these other medical issues simultaneously. So today in our clinics, we actually now manage and try to proactively screen for all of these medical circumstances, even though our level of expertise is actually emerging over time. Okay? So in our clinic, we started with just appreciating renal disease and later cardiovascular disease. But as our patients are now living into their second, third, or even fourth decade with HIV, we now have to be increasingly aware of how to manage all of these medical comorbidities and how to navigate the multiple healthcare systems that provide care in these areas. So it does look like we have some answers. Oksana has answered cardiovascular disease. I can't see the second one. The two other people have answered all of these. So this is largely consistent with the emerging care circumstances in our country and in Western Europe. Thank you for answering the questions. So what the next graphic then is really the statement of this thesis. As patients infected with HIV are living longer, there's an increasing amount of comorbid disease present in this population. In fact, comorbid disease that is in addition to the kinds of comorbidities that we saw during the AIDS phase of the epidemic, whether they be pneumocystis, pneumonia, or tuberculosis. And so this aging population has a set of comorbidities related to aging, related to advancing immunosuppression, as well as an increasing prevalence of traditional risk factors among them. And as we think about long-term survival, then we need to think about how to best prevent these kinds of complications, how modifiable risk factors can be addressed, and developing long-range infrastructural and strategic strategies to maintain the long-term health of individuals living with HIV. Now, because of time, I'm not going to go through all or try to address all 4 of these comorbid conditions, but rather focus on 2 of them. But I would encourage you to consider the effects of all of these in the strategic management of patients in your centers. The management of and screening for these kinds of comorbidities is still an emerging area, both for evidence-based medicine, as well as an emerging area for national and international treatment guidelines. Perhaps one of the best, in my opinion, one of the best tools and contemporary tools for this is shown on this slide, which is a representation taken from the European AIDS Clinical Society and published this year. This is a comprehensive view of strategies for screening and takes the best evidence approach both from the general population as well as the HIV population. It's available online. I would encourage you to take a look at this. And one can also download my slides here for your more review at your own leisure. So next, I'd like to cover, really, I'm going to focus on 2 areas of those comorbidities, namely renal health and bone health. These have been 2 areas where I've been involved and charged with being the principal investigator for Centers for Disease Control analysis of a large cohort of patients in the United States. So I'll try to give you both the evidence-based and the clinical practical aspects of those observations. So this graphic reminds me to tell you that, one, that HIV, or people living with HIV, have long been known to have renal complications, but also that the prevalence of kidney disease in the HIV populations has increased over time, including our analysis from Centers for Disease Control, published by Frank Palella in the recent past. What's also interesting to note is that the proportion of patients who are dying of HIV who have renal complications has increased in the last 2 decades. And again, this has significant implications in terms of the management of comorbidities in patients who are long-term survivors. This next graphic serves as a reminder that patients who have kidney disease can have kidney disease both from the perspective or have pathology that is both glomerular as well as tubular. So one large cohort analysis has suggested that glomerular filtration is decreased in as many as 30% of HIV-infected persons. A separate analysis suggests that as many as 50% of infected patients may have tubular dysfunction. And a more recent multi-site study from Europe and North America reiterates the finding of decreased glomerular filtration present in as much as a third of patients living with HIV. So what this means clinically is that it is twofold. One is that most of this disease is silent and asymptomatic. And so as clinical managers, one needs to figure strategies or be mindful of strategies that identifies even modest decreases in renal function and keep that information present in the clinical charts. Now, patients who are living longer and or older have multiple risk factors for having renal dysfunction. It's long known that people who are older, it's normal to lose glomerular filtration as we age, and so older age is a risk factor for renal disease. But In addition to that, other renal risk factors are more prevalent in older populations. These include diabetes, hypertension, and cardiovascular disease. And among HIV-infected populations, there's also a higher prevalence of other comorbidities, including tobacco consumption and viral hepatitis, all of which can conspire to increase the risk of having renal dysfunction in a population of people living with HIV. So this is one other question for you to answer in your chat section of the webinar. How many of your patients have more than one risk factor for kidney disease? The answers are: number 1, none of my patients; 2, a small proportion; 3, a growing proportion; and 4, a very significant proportion. If you could answer, it'll give me some basis for knowing a little more about the patients you care for. So one answer says 3, a growing proportion of patients. And this is actually very similar to our clinic in the Midwest of the United States. In our clinic, approximately 20 to 30% of patients have some degree of tubular dysfunction. A similar small percentage of patients have some evidence of abnormal protein excretion in urine. So it is a significant minority of patients currently that we have to be mindful of their renal function. And we do so both before we initiate therapy and then during the course of treatment with antiretroviral therapy. So I mentioned that HIV patients have a number of pre-existing risk factors for having kidney dysfunction. I also mentioned that HIV itself seems to be related to having renal disease. And so other studies have shown us that there are HIV disease-specific factors which also seem to contribute to risk of kidney disease. They include nadir CD4 count and the direct toxic effect or side effect profile of specific antiretroviral therapies. And so these are the factors that as HIV clinicians we have, one, a familiarity with, and secondly, some degree of effect in terms of our clinical management decision making. This next graphic, make sure I have the right slide, shows that there are multiple ways in which antiretroviral therapies can affect kidney function. So some medications can cause acute kidney injury. Other medications, those medications include, for example, tenofovir, ritonavir, and didanosine, which have been associated in cases of acute tubular necrosis. Crystal nephropathy has been associated classically with indinavir and more recently with the protease inhibitor atazanavir, shown here. Fanconi syndrome, more commonly and classically associated with tenofovir, and so on. Okay? So the point here is to recognize that there is the possibility that antiretroviral therapy itself can contribute to renal injury. One capitulation of this thesis is shown in this next graphic, which is a summary table taken from Mockcroft's publication from the EuroCETA cohort, looking at several thousand individuals in Western Europe. What this graphic shows is that the presence of chronic kidney disease is associated with exposure, or specifically increasing exposure to certain antiretroviral medications. So these include 4 different HIV protease inhibitors, shown here, and the nucleotide inhibitor tenofovir, shown above. So the increased hazard ratio of having chronic kidney disease is increased anywhere from approximately 5% for lopinavir to as high as 40% for ritonavir boosted atazanavir. An additional way of looking at this data set is shown in this next graphic. This is from the Mawcroft-Eurosita analysis. What is the additional information shown here is that the proportion of patients who have renal dysfunction increases with increasing exposure or duration of exposure to the individual agents. So it's this kind of information that looks both at the prevalence of chronic kidney disease as well as the time or exposure relationship to the agent that reinforces the thesis that one needs to be careful with the administration of these medications in patients with underlying kidney disease or risk. It's perhaps germane to note that other medications were not associated with this risk. They include the nucleosides abacavir and lamivudine. So taken together, this has led a number of agencies to provide guidance as to how patients should be managed with regard to either prevention or management with chronic kidney disease. So these are guidelines taken from the European AIDS Clinical Society, again available on their website. And notably, there is both instruction for the management and observation both of protein excretion, urinary protein excretion, that's noted here on the left, as well as estimation and monitoring of glomerular filtration. And this is recommended to be done essentially in all patients living with HIV. There are, because of its association with renal disease, there's an additional set of guidelines for monitoring and management of patients who are initiating or receiving tenofovir-based therapies. And in our country, tenofovir is very widely prescribed, and so an understanding of the best practices for management of tenofovir-receiving patients is therefore important. So let me summarize the renal component of this discussion to say that HIV, there are multiple risk factors for renal disease in HIV-infected populations. They include HIV itself, and as well as the increasing awareness of aging and multiple comorbidities that contribute to chronic kidney disease in these populations. Screening for chronic kidney disease is recommended for all patients at time of diagnosis, before initiation of antiretroviral therapy, and at least annually, but in our practice, probably every 3 to 6 months in patients who are receiving antiretroviral treatments. There are specific monitoring guidelines for patients who are receiving tenofovir, and we try to increase the level of surveillance among those patients. Next, let me turn attention to the second area for our discussion today, and that is namely bone health in HIV-infected individuals. Only a few years ago, this was a very underappreciated area, one that we paid essentially no attention to in our clinic program. A clinic program that takes care of approximately 1,000 individuals living with HIV. We really failed to appreciate the concern or the risk factors for bone disease in this population. So I have one additional question for you, and that is, among people living with HIV, what are factors associated with abnormal bone mineral density or bone disease? So the answers are, number 1, hepatitis C infection, 2, nadir CD4 count, 3, antiretroviral therapies, and 4, all of the above. If you could take a few minutes to answer your questions on the chat section. Looks like Elena is the most rapid respondent to this. She says number 4, all of the above. Svetlana says 4 as well. And in fact, gratefully, you're all correct. And let me in part show you why in the next section of this discussion. So until very recently, again, we really did not appreciate the prevalence of abnormal bone mineral density in HIV populations. This was in part because we did not think about long-term survival in this context, and secondly, because most clinicians do not see or have evidence of fractures. This graphic comes from Dr. Todd Brown's meta-analysis published in the journal AIDS in 2006, and summarizes the increased prevalence of osteoporosis in populations of people who are HIV positive compared to those who are HIV negative. In every study, the point estimate of osteoporosis was much greater than 1, shown by the solid boxes in this graphic. And when all of these studies are combined in the meta-analysis, and important to remind you that these studies represent multiple different populations of patients in multiple countries with multiple risk factors for HIV. And overall, the prevalence of osteoporosis was about 3.5-fold increased, or 350% greater than the HIV negative populations. So a much higher prevalence of osteoporosis. Similar conclusions were drawn when one looks at the other elements of or diagnoses of abnormal bone mineral density, namely osteopenia. So whether one looks at osteopenia or osteoporosis, a higher prevalence present. This next slide summarizes our analysis of the SUN study cohort in the United States. This is a study of approximately 600 individuals in 4 centers in the U.S. We were able to compare in a age and gender matched fashion a HIV negative population, and also found this increased prevalence of bone mineral disease. Overall, we found that the prevalence of that low bone density was in approximately 2/3 of individuals, and the prevalence of osteoporosis was 10-fold increased compared to HIV negatives who were matched for age and gender. Moreover, what we showed was that there were factors that seemed to be that were associated with HIV infection itself, namely CD4 count nadir and duration of HIV infection. Both were associated with an increased risk of having osteoporosis and osteopenia. So, for example, those patients who had a baseline CD4 count at study entry of less than 200, namely patients who had an AIDS diagnosis, their overall risk of having osteoporosis was nearly 2-fold increased compared to the general population. So while these data taken together say that osteopenia and osteoporosis is prevalent in people living with HIV, they did not ask the most critical or did not address the issue of end organ disease with regard to fractures. That answer came in one older study and several more recent studies. This is the first publication from 2008 from Steve Grinspoon's group in Massachusetts, which looked at the entire population of HIV-positive individuals at the Massachusetts General Hospital, compared HIV positives to HIV negatives. So on the left side of this graphic are women, and on the left, men. The graphic shows or is partitioned by age, and so one can see that in the upper curve, at each age group for both genders, people who are living with HIV have more fractures than age and gender matched HIV negative individuals. This analysis was restricted to just fractures at the hip, wrist, and spine. The classical sites that are associated with fractures or fragility fractures, or fractures associated with osteoporosis. So this was a single study from a single site. Most recently, we published this analysis from our CDC, or Centers for Disease Control HOP study. This analysis looked at approximately 6,000 individuals in 10 cities across the United States, compared them in an age and gender matched fashion to a representative population in the general population of approximately 2 million individuals. We found that over a 10-year period, the HIV population was experienced than the HIV negatives. We also found that older age was associated with this risk of fractures, a history of substance use, again having a nadir CD4 count less than 200, and hepatitis C co-infection. Perhaps also related to the pathophysiology of this circumstance was that when we looked at all fractures among HIV positives, there was a greater proportion of fractures that occurred at these osteoporotic fragility sites, namely of the hip, the wrist, and the spine. And this was true for both men and for women. Again, suggesting that there was something about the population of people living with HIV itself, comorbidities, or aging that placed people living with HIV at greater risk. So if we return to the previously published analyses, we find that the overall prevalence of osteoporosis is, firstly, significantly increased in the HIV population. But also, there were signals that related risk of osteoporosis to antiretroviral therapy. So this slide summarizes some of that information and notes that, for example, patients who received a HIV protease inhibitor were approximately 60% more likely to have osteoporosis compared to those who were not receiving protease regimens. This next graphic comes from the multi-center study called SMART. This study, if you recall, was a study that randomized, a very large study that randomized individuals to either receive continuous antiretroviral therapy or intermittent therapy, a therapy that was discontinued when CD4 counts reached 350. The overall results from the studies showed that patients who received continuous therapy actually had fewer medical complications. Fewer AIDS complications, fewer deaths, fewer cardiovascular events. But in contrast to this general conclusion, patients who received antiretroviral therapy actually had greater decreases in bone mineral density at the hip and the spine over the duration of the study. So this was contrary to the overall conclusions of the study and would lead one to conclude that there was something about antiretroviral therapy itself that resulted in decreases in bone mineral density. So I already mentioned that there was an association with protease inhibitor exposure compared to non-protease inhibitor exposure. There's also a growing and accumulating body of evidence that suggests that there's also a relationship between nucleoside inhibitor exposure and bone mineral density. So this is data that was presented most recently by Grace McComsey for the AIDS Clinical Trials Group study 5224. This is the study that randomized patients to either receive abacavir lamivudine or tenofovir M-tricytidine as components of multi-drug therapy. The graphic again shows bone mineral density or change in bone mineral density over time. In this analysis, patients who received tenofovir, actually overall, patients who received therapy had decreases in bone mineral density both at the hip and the spine, but that there was a strongly statistically significant difference between patients who received tenofovir M-tricytidine, shown in the bottom two curves here, compared to those patients who received abacavir lamivudine therapies in the upper curves. So this analysis looked at patients who initiated antiretroviral therapy. It remains unclear as to why patients overall lost bone mineral density, and this is an area of considerable interest right now, and again may be dependent on additional bone health risk factors. A different circumstance exists, however, in patients who are currently receiving successful therapy. So this is, again, patients who have suppressed viral loads and are initiating new therapy or switched to one of two different nucleoside regimens. So this is a study called STEEL. It was a study conducted in Australia presented and now published in peer-reviewed journals. This study reached the same qualitative conclusion that suggested there was a difference between patients' bone density over time as a function of new receipt of either abacavir lamivudine or tenofovir emtricitabine. So again, here patients who received tenofovir and emtricitabine lost more bone mineral density compared to those who, in the upper curves, received abacavir-containing therapies. So again, overall, an effect related to antiretroviral therapy in the larger constellation of bone health and bone disease risk factors. Now, taken together, this leads several organizations to consider new guidelines for the management and prevention of bone disease in people living with HIV. These are the European AIDS Clinical Society guidelines, again, available online, where overall the European guidelines recommend that people living with HIV who are over age 40 have screening for bone mineral disease. This is broken out into several different components. One related to the use of online calculators such as FRAX and assessments for fall risk called FRAT, and gives specific guidelines as for who to screen and when to screen. From a practical perspective, in the U.S., we do not yet have published guidelines for this, and so this is an area, again, of considerable interest. In our clinic, what we are trying to do now is to assess risk of bone disease in all patients, and this means both collecting historical information as well as assessment for modifiable risk factors. These include calcium and vitamin D intake, they include tobacco consumption, they include weight-bearing exercise, testosterone levels, thyroid disease, renal disease, and so on. It's a growing area of concern, in part because we are still learning how to best manage this disease entity. So to summarize this section, we have found in the last several years that reduced bone mineral density is highly prevalent in HIV-infected populations. These include data that come both, not just from North America and Western Europe, but unpublished data to date that find draw similar conclusions in Latin America, and I'm aware of at least preliminary data that's emerging from one center from the Russian Federation, which corroborate the larger conclusion of the prevalence in additional populations of individuals. I've shown you some data that suggests that HIV infection itself, and specifically the extent of HIV infection or disease, is an independent risk factor for having low bone mineral density as well as for fractures. There is a increasing or higher incidence of fractures in HIV-infected individuals. This includes our data from Centers for Disease Control and a more recent presentation this summer from the U.S. Veterans Administration hospital system. There are also declines in bone mineral density that have been seen in patients who receive antiretroviral therapy, and specifically certain types of antiretroviral regimens. And currently the European Society recommends screening for all HIV-infected individuals over age 40. Okay. Victor, is this the cardiovascular section?
Yes.
Okay. Let me briefly summarize a few points regarding the third area of comorbidities, namely cardiovascular disease. This is really in a sense, the conclusion slide, which is to remind you in the brief remaining time that HIV itself is an independent risk factor for prevalent cardiovascular disease. Our analysis from Centers for Disease Control has shown that uncontrolled viremia is probably the largest modifiable risk factor with regard to HIV disease. Like the story for bone disease, there are other risk factors which are common to the general population. There are a number of guidelines that talk about the prevention and management of heart disease in HIV-infected individuals, and the use of a variety of risk calculators, including the Framingham risk equation for assessment of risk. And that lastly, that individual drug regimens differ in cardiovascular risk profile. And so regimen selection should be tailored to the background risk for cardiovascular disease. A story that is very similar to the situation for kidney and bone disease. Okay, I'm going to skip forward in the interest of time to really my concluding segment, which has to do with how do you best integrate all of this emerging information in the HIV clinic. This is an introduction, I hope, for you to a program that I've been involved with that has been sponsored in an independent fashion from Veith Healthcare, a program called My HIV Clinic. My HIV Clinic is one of many online resources that I think that you should be aware of and may be helpful, certainly have been helpful for management in our clinical setting. Include online resources to assess cardiovascular risks, such as the Framingham calculator or SCORE, a variety of reference interpretations for coronary calcification, tools to estimate glomerular filtration. These include the MDRD and Cockcroft calculators. We actually use these in the clinic on an everyday basis. A reference to the FRAX calculator for fracture risk assessment. This is an online resource that has been validated in multiple countries and provides an estimate of risk of all fractures or major osteoporotic fractures, as well as a variety of questionnaires to assess risk or diagnostic indices for things like endocrinologic dysfunction, neurocognitive dysfunction, including the International HIV Dementia Score. This is something that we are just starting to learn to use in our clinic to assess for or screen for dementia in our patients. So multiple areas where HIV doctors are becoming asked increasingly to try to assess for other risk factors and other comorbid illnesses, often areas where we're not particularly expert in, and so we need to learn how to, in a streamlined fashion, to incorporate both screening and management of these disease entities. So this brings me to the topic of My HIV Clinic, an online resource, the homepage of which is shown on this graphic. This is a tool that is aimed at trying to teach HIV experts and non-experts in the management of these new areas of medical concern. The program tries to incorporate concise summaries of the pathogenesis, management, and treatment of health and illness in a variety of topics. The education material and links contained within this includes both contemporary treatment guidelines, references, and these online calculators. The content on the site has been generated with discussion with experts from around the world, and so this is a summary of some of the people that have helped so far. They include, of course, me, but include experts from all over the world, and some of the highest quality clinical experts that have given insight into the management of these areas. So my HIV clinic is currently launched in the world, excluding the United States. It is currently in English, but we have hopes that in the very near future the content will be translated into other languages, including Russian and Spanish. There are 3 content departments currently. They include HIV in older individuals, cardiology, and endocrinology. They will include future departments and areas of expertise in neurology, oncology, we hope in the near future tuberculosis and hepatitis. So I would encourage you to take a look at the site and give us feedback as to whether you think this has been a useful resource for you here in the Russian Federation. Also give us feedback as to what topic areas you think are most important to see in the next iterations of the resource. So I've reached the end of my time. I want to thank you all for joining us here online. I hope that this online discussion has been of at least introductory value to you. I look forward to seeing perhaps your commentary and again, welcome your input on our discussion. So this is the time now where if you have questions, you can enter this into the chat room. My colleague Victor from American International Health Alliance can help me translate your questions, hopefully, into answerable questions in English. So if you have any questions, please feel free to enter them into the chat section. Okay. Well, if you have no additional questions, I thank you for your attention and time spent here on the webinar. Please stay tuned to the American International Health Alliance emails or Facebook page for additional announcements about webinars. They will largely be available in Russian for you, and we hope in the future that we may have some opportunities to do these kinds of programs across our language boundaries. And again, I thank you for your attention today and hope you have a good evening. Oh, sorry, we have a question.
So just need some time to translate. So people from Yekaterinburg will thank me for the workshop.
Well, thank you for your commentary from Yekaterinburg. Looks like there's a case of a 37-year-old man infected in 1996.
He feels sick.
Feels sick.
On his last treatment of this is the screen.
Mm-hmm. The last treatment was tenofovir, emtricitabine, and Kaletra. And has facial lipodystrophy.
So the question is whether they need to change the scheme and whether they need to do the plastic surgery.
Okay, and the question is whether the scheme needs to be changed or to entertain plastic surgery. So lipodystrophy has been a very significant area of concern both for medical providers as well as patients over the years. And it has been an area that we have focused a lot of both research and effort and spent quite a bit of time thinking about from a practical treatment perspective. What should be stated, much like the story for these other end organ diseases, is that lipodystrophy is not just related to antiretroviral therapy, but is a consequence of, or at least there are multiple factors associated with risk for lipodystrophy, and they include particularly the patient's nadir or lowest CD4 count. There have been associations with lipoatrophy with certain HIV medications, namely stavudine and didanosine, and zidovudine. So the thymidine analogs and didanosine have been associated with increased risk of lipoatrophy. Of note, the patient that you're describing actually is not receiving any of those medications, although I wonder if he had received those in the past. What is unfortunate about lipoatrophy is that therapeutic switches have largely not been associated with very significant clinical improvement. So that's consistent with the idea that the medications themselves are probably not a major contributor to lipoatrophic risk. So we've not been particularly happy with treatment switches in terms of reversal of lipoatrophy, although they have seemed to mitigate additional development of lipoatrophy over time. With regard to plastic surgery or, let's say, other medical interventions, there are some patients who have received various kinds of implants, either silicone implants or autologous fat transplants with variable success. What we have used for the facial lipoatrophy has been a product called, or a product which is L-polylactic acid, or goes by the trade name of Sculptra in our country. It is approved by the U.S. FDA for the treatment of HIV-associated lipoatrophy, and has been a useful adjunct for patients who are otherwise clinically doing well, namely have normalized CD4 counts and controlled viral replication. It is a non-permanent solution, but has yielded some benefit for patients, actually considerable benefit for some patients, but is unfortunately rather expensive and requires additional investment of effort and time. So facial lipoatrophy, significant problem. There are 2 FDA-approved medications. One is called Sculptra, the other is called Radiance. And they both seem to provide some relief, at least cosmetic relief, for patients who have lipoatrophy. So that's hopefully an answer to the first question. If you're welcome to, please, if you have any additional commentary, feel free to place them into the, type them into the chat portion of the webinar. Oh. Well, you're welcome very much for the answer. I hope that's of some utility for you. Again, the Sculptra therapies now we do in our clinic, it's actually a very simple procedure. It takes 15 to 30 minutes in the clinic. And patients, by and large, seem to appreciate the cosmetic benefits. So we have any other commentary? No? Okay. Well, it is approaching the end of the hour. Again, I do very much appreciate the opportunity to dialogue with you. If by voice from my side and by text from yours. For those of you who would like to contact me, please feel free to do so. You can do so indirectly through the American International Health Alliance, and they can put you in touch with me. You're also welcome to email me directly at byoung at... Oh, I can type this in myself, I think. Just learning this technology. My email address is as follows: byoung@rockymountain